We will be switching gears. I'll be talking on something which is not usually discussed. Role of PICC, especially in regimens where we give 5FU. In GI, it is commonly used in Folfox or Folfiri or Folfirinox, and in head and neck, we do use it routinely. So, once the logistics are set, PICC is both for patients and both consultants both. Uh, we'll start discussing a bit of it in Indian data on it too. Next slide, please. So, as we all know, venous access is a critical thing for all cancer patients. Chemoports and PICC is something we use most of the time. At least I usually use chemoports for breast cancer patients, and for 5FU infusions, I generally use PICC. But both are a valid option in either of the situation, and especially in regimens like TPS or Colfox, where we know the definitive time of treatment, 2.5 months for TPF, PICC would be a better option than using chemoport, because we want it for some period of time. That is what I believe. Next slide, please. So we'll try to understand the global guidelines, Indian practices, what are the barriers to it, and try to arrive at some consensus for PICC using it. Next slide, please. So, venous access, initially we think that that is not a major issue, but eventually once patient is on treatment or at some point of time, venous access is something which we need to think over, especially in patients where treatment goes on for longer period of time. Uh, Venous access will also help for supportive treatment, blood products, antibiotics, and not just chemotherapy. So, do we need Indian algorithm for it, or Indian version of how to use PICC in our patients? I feel we need Indian version because the setups in which we work is different. The supportive staff which we have is different, and it is not very easy to have a PICC nursing team who will look after everything in every center. So a mix of paramedical staff, nursing staff, clinical staff have to look after PICC in most of our situations. So is the awareness lacking? I think most of us want to use it, but it is more of issue in logistics rather than awareness where we fail to use. So is training and opportunity or material available easily? It is surely available easily. There are centers in India where PICC training is done for nursing, paramedical staff, or even for medical officer anesthetists. Uh, are we bit casual for venous access and its complication? I think we are bit casual in fraction of patients. Dedicated venous access team is something which is required and which needs to be strengthened, but we uh, are not as aggressive in doing it as it should be. Next slide, please. Next slide. So how it is used globally, or what the data is available, from what the literature is available, 70% patients receiving irritant vesicant chemotherapy experiences phlebitis. 22% patient receiving irritant vesicant chemotherapy experience extravasation. Now, when I read it for the first time, this was a bit of a surprise to me, because I thought that 22% is not what we see in our routine practice. It is much lower than that. Maybe our patients are a bit tolerant and they're not reporting small phlebitis or so. But that is something which we should look for when patient comes for second, third, or fourth cycle, especially when vesicant or irritant is used. Next slide, please. So this is broad guidelines where if we want to use up to 5 days of treatment, peripheral IV cannula is something which is okay. For critically ill patients, central venous catheters is something which is preferred. For cancer patients receiving chemotherapy, PICC, port or tunnel catheters like Hickman catheters is something which is preferred. So this is global guideline based on Michigan appropriate guide for intravenous catheter access. Next slide, please. So what is the ideal situation in which we should use venous access as per the same guidelines? So PICC should be used for short time, for medium duration of time, or even beyond 1 month of time. Tunnel catheters should preferably be used when patients are requiring the drug for more than 15 to 30 days or more than 30 days, and port generally when more than 30 days of irritant vesicant infusions are planned. Uh, Frequent phlebotomy for blood collection can be used PICC for sampling. So PICC can be used for sampling. Catheters can be used for sampling. Port is something which should be avoided for sampling, just for the reason because once it is infected, it is difficult to get rid of that infection and it will hamper patient's treatment too. Well, if PICC or tunnel catheter are taken care of appropriately, chances of infection are not as high as it is in port. Next slide, please. So, what are the parameters which we see while we are planning some venous access device? Which type of chemotherapy are used? What is the duration of treatment and indwelling catheter time? Intensity of dose? How patient's veins are, vascular integrity of patient, and patient appropriateness, whether patient is living nearby and can come for dressing and PICC care, or patient is living far away and it is difficult for them to arrange for PICC care. Next slide, please. So we are all aware what are the vesicant and irritants chemotherapy drugs. So anthracyclines, vinca alkaloids is something which I'm always afraid of as vesicant, because once you see extravasation with these drugs, you will never forget that in some patient it will be the most troublesome thing. It may be more concerning than the cancer itself. Again, in irritants, you need to be careful, especially for 5-FU, dacarbazine, where we see a lot of local site reactions. So for all vesicants and irritants, beyond doubt, ideal situation would be to use some form of venous access device, be it PICC or port or Hickman catheter. It will not only prevent extravasation and thrombophlebitis, but also will avoid frequent pricks for blood sampling and repeated infusions, blood products or antibiotics, whatever as needed. Next slide, please. So across all the guidelines, PICC is something which is recommended. The duration of PICC recommended. So we can use PICC up to 12 months for IV therapy. In MD Anderson, there was a report where they have used it up to 34 months. NHS guidelines again say that you can use it till many years. And you can, so generally we try to do insert port when we are using it beyond 6 months or 12 months. But if PICC is taken care of and a good PICC is inserted, we can use it beyond 6 months, even up to 12 months or even up to some years. Next slide, please. Again, this is an experience of 269 PICC in 950 patients. Most of them were solid tumor patients. So median was 184 days. So it crosses 6 months. And the range was 15 to 1384 days. So they have used PICC for more than 1000 days. So the message is that even beyond 6 months, PICC can be taken care of. So that is something which we can consider, especially in our hematological malignancy patients. And most of our solid malignancy adjuvant treatment or neoadjuvant treatment would get over within 6 months. So PICC is a good option. We can remove it very easily, which is not as easy as in port. Port is not as easy as PICC. Next slide, please. Next slide, please. So now this is an bit of hypothetical situation, but something which will surprise us. That have we ever estimated the amount of pricks patient has to go through? Say, for example, in ovarian cancer or lung cancer, when patient is undergoing multiple line of treatment. Say patient has received 2 or 3 lines of treatment, which is common in ovarian cancer and in some lung cancer. The number of pricks the patient has to go undergo is significant. Next slide, please. And if we think of that, then probably PICC port or some vascular access device is something which we should think of. So if a lung patient is receiving 3 lines of treatment, uh, PEMSIS, docetaxel, or some form of Taxane, and then vinorelbine uh, over 1 year. So they've estimated that assuming there is one episode of febrile neutropenia and average blood sampling during treatment would be 25 needle pricks. So across 6 cycles or 4 cycles, whatever we have planned, the number of pricks would be this. They have estimated that a patient would undergo around 72 pricks in a year. This is a lung cancer patient. This is not a 5FU infusion patient, or this is not a hematological malignancy patient where number of pricks would be significantly high. Obviously, this is an hypothetical case, but if we track patient for 1 year, the number would be near to this, if not exactly 72. Next slide, please. Next slide. So what are the things which is preventing us from using some form of vascular access device, PICC or port? So cost comparison, we all know that port is costlier than PICC. Port would require some form of anesthesia. Many a times it will require general anesthesia. PICC, if we are getting our paramedical staff trained, then no medical or anesthetist or medical staff is required. Nursing staff can easily take care of PICC, insertion, maintenance, counseling, and everything. Next slide, please. Next slide. So cost comparison, everyone knows that obviously PICC would be cost effective when compared to port. Next slide, please. So nurse-led PICC insertion is something which we should aim at. Obviously, now this will have some medico-legal implications. Not every centers are comfortable, and not everywhere nurses are uh, efficient enough or trained enough that they can do PICC insertion. So if we can do nurse-led PICC insertion, then it will be obviously more cost effective. Next slide, please. Again, it differs in different institute, but USG guided PICC insertion is safer than doing it blindly. So that is also which we should consider. Chances of failure would be less if we try to do the catheters available. Is open-ended PICCs, valvular or close-ended PICC, single lumen, dual lumen, or triple lumen PICC. So most of the time we use double lumen or single lumen PICCs. Triple lumen are generally not used unless we do bone marrow transplant, and where tunneled catheter is generally used, or central catheter is used, depending on different centers where practices would differ. Next slide, please. Next slide, please. So this is a Grosong PICC which is routinely used everywhere. It is high quality PICC where I've seen that people can, if maintained well, we can use it beyond 6 months also. Next slide, please. Next slide, please. So these are some functions of PICC. Now, this is something which we should be aware of, that we have online course for PICC, and even there are 5 centers where they train are paramedical or nursing staff for PICC insertion, care and maintenance. So this is something which we should be aware of and should explore if we have not explored. Training, especially training in hands-on training at 5 centers where it is available. Next slide, please. These are the 5 centers. Next slide, please. Next slide. These are the BD sponsored, Grosong PICC sponsored training programs which are going on, where they train our paramedical staff or an anesthetist or a medical officer for insertion, care and maintenance, everything. Next slide, please. So for PICC, the most important thing after insertion would be the maintenance. We need to ensure that if PICC is inserted, then patient has to undergo regular flushing and regular dressing. If that is not taken care of, then no effort of insertion or cost of PICC, we need to replace it or we need to discard it. So we need to sensitize patient and our nursing staff beforehand, before starting PICC insertions at our center. We need to sensitize both patient, nursing staff, paramedical staff regarding the importance of PICC, importance of dressing and flushing. Next slide, please. So these are some add-ons available which would help to help in care and maintenance of PICC. Next slide, please. Next slide. So pre-filled flushes are also available, which would be helpful for patients if they are not coming down to the centers. If they are doing it at nearby places, then pre-filled flushes would be helpful. So summary, central venous access device is recommended for all vasecant and irritants in patients where chemotherapy, where pH is less than 5 or more than 9, infusates with osmolarity of more than 600, total peripheral nutrition, blood and blood products infusion. Next slide, please. So we need to make a formal habit of checking and documenting venous status for most of the patient while we are starting chemotherapy. There should be an option of vascular access device to most of the patients upfront while we are counseling for chemotherapy. And contrary to common misconception, PICC can be successfully managed beyond 6 months or even more than 1 year. And it will be helpful in continuous and intermittent chemotherapy both. Next slide, please. Next slide, please. I think this is the last slide. Thank you.
Thank you, Dr. Rushabh.